Welcome, everyone. My name is Lisa Willems, and I am the Senior Product Manager focused on hematology testing at Mayo Clinic. I will be moderating today's session. I would like to welcome you to our Advancing Care Through Genomics virtual speaker series. This particular series focuses on presenting new information and ideas in laboratory medicine and pathology in individualized medicine. This is the second presentation in our multi-part series. Before we get started, I would like to mention to please use the Q&A in Zoom. It's located at the bottom of your screen to submit your questions. We will have time for Q&A at the end of today's presentation. We are very pleased to welcome Dr. Saad Kenderian, our featured speaker today. Dr. Kenderian is a consultant in hematology at the Mayo Clinic, Rochester, with joint appointments in the Department of Immunology and Department of Molecular Medicine. He holds the academic rank of Assistant Professor of Medicine, Oncology, and Immunology at Mayo Clinic College of Medicine. As a physician scientist, he directs a federally funded translational laboratory program focused on T-cell biology, cellular engineering, and chimeric antigen receptor-T cell therapy, also known as CAR-T. Since 2019, 3 clinical trials have been translated from his laboratory. 2 of them are multi-center trials. He has also authored more than 90 manuscripts and book chapters. He is an inventor on multiple patent applications and is the principal investigator on 5 active clinical trials. Dr. Kenderian will be talking today on CAR-T cell therapy. Where are we now and in 2030? Treatment with CAR-T cells is a form of individualized therapy that utilizes the patient's own T cells to treat and kill cancer cells. T cells are isolated, expanded, and engineered in the lab to recognize cancer cells. With the advancement in immunology, genome engineering tools, and molecular biology, CAR-T cells are being engineered to be safer and more effective in cancer and non-cancer applications. Now, please join me in welcoming Dr. Kenderian.
Thank you very much, Lisa, for the kind introduction. And thank you for the invitation. It's a pleasure to participate in this virtual series. These are my disclosures, and we work with several of the biotech companies in the CAR-T space to translate discoveries into the clinic. And I am as Lisa mentioned, principal investigator on several clinical trials. So what I hope to cover over the next 40 to 45 minutes is to quickly outline what is CAR-T cell therapy and where we are now. What's the efficacy of CAR-T cell therapy in the treatment of hematological malignancies? And what are the current challenges and limitations and new directions in the field? I think it's important to note that the concept of CAR-T cell therapy or chimeric antigen receptor T cell therapy is old. The concept was first pioneered by Eshar and colleagues in 1989. At that time, it was referred to as a T-body or a chimeric receptor. And what it is that the CAR is a synthetic protein that has a part of a monoclonal antibody, a single chain variable fragment. This is the part that binds to an antigen that is fused to a transmembrane domain and fused to a T cell signaling domain, and hence the name chimeric, because it incorporates part of a B cell on the outside of a cell, fused to a part of T cell, a signaling domain of T cell on the inside of the cell. And that CAR went to the clinic and in the 1990s, and what we learned is that the efficacy of this CAR was pretty modest. And then later on, we learned that the T cell actually need 2 signals to work. And that led to what we call now as a second generation CAR, which is the CAR that is currently FDA approved, that I will be discussing during the presentation. So this CAR incorporates, in addition to CD3 zeta signaling domain, a co-stimulatory domain, such as CD28, 41BB, or any co-stimulatory domain that if you like. And since then, there have been efforts to improve on this CAR by adding additional signaling domains, additional trafficking molecules, cytokines, and something that investigators call third generation, fourth generation, fifth generation CAR-T. The concept of CAR-T is really synthetic biology at its best, because how you engineer the cell really directs how the cell behaves in vivo. CAR-T cells are living cells, and the molecule that is incorporated into the engineering dictates what happened to the cell. If they're going to be more cytotoxic, they kill more effectively, or persist more, or if they differentiate to certain phenotype. And then to make a CAR T cells, this CAR molecule is inserted into a T cell by a virus or lentiviral vector. So here in this cartoon is shown by a lentiviral vector. This CAR molecule is inserted into the T cell. Through the lentiviral, it goes into the nucleus, and then it gets expressed on the surface. And now the T cell expresses the CAR molecule on the surface that targets the antigen, in addition to the native receptor on the T cells. And then that CAR molecule hunts for the antigen, finds the antigen, and gets the T cell to kill the antigen, to kill the tumor cells. And the process today is an autologous process. So by that, it means that to make CAR T cells, we take T cells from patients through a process called leukapheresis. We isolate the T cells in the lab, so the cells are isolated from patients, sent to the lab. The T cells are isolated. And in the lab, over a period of 7 to 10 days, the T cells are stimulated so that they grow by several folds. And during this period of time, they are engineered with either virus or non-virus, so that the T cell is now a CAR T cell. They express the CAR T on its surface. And then at the end of this period of expansion, now anywhere between 20 and 100% of the cells, of the T cells, are CAR T cells. Then patients receive low-dose chemotherapy, lymphodepleting chemotherapy. This is to create a homeostatic environment for the adaptively transfused CAR T cells, if you like to make room for the new CAR T cells. So the purpose of this chemotherapy is not really to attack the patient's cancer cells. And then following the lymphodepleting chemotherapy, they receive their CAR T cells, the autologous CAR T cells. So the process today with the FDA approved product is that the cells are collected, are shipped to the company. The company make CAR T cells, and they shipped back to us. And that period of time, it takes anywhere between 3 to 4 weeks. Of that, about 7 to 10 days is the actual manufacturing of CAR T cells in the lab. And then CD19 is a target that is commonly sought after in the field of immune therapy and CAR T cell therapy. CD19 is expressed on B cells and expressed on all leukemic B cells and cancer B cells. And therefore, it's sought after for the treatment of B-cell lymphoma or B-cell acute lymphoblastic leukemia. CD19 is uniquely expressed on all cancer cells and is not expressed on normal cells. Therefore, it's safe to target. The only expression of CD19 is on normal B cells. And therefore, when you use CD19 targeted therapy, the normal B cells are depleted, but depletion of normal B cells, generally speaking, is easy to deal with in the clinic through replacement of immunoglobulins with IVIG. But that's why CD19 is a commonly sought target. And that's critical in the field of CAR T cell therapy. So CAR Ts that target CD19 are referred to as CAR19. But that's critical is in the field of CAR T cell therapy, because if your target, if the CAR Ts are directed and engineered to target an antigen, to target a tumor antigen that is expressed in normal tissue, that can result in significant toxicities. And when a story is the HER2 CAR T cell therapy, HER2 is widely expressed in breast cancer and ovarian cancer. But is also expressed on the heart and the lungs. So the first patient that was treated with HER2 for ovarian cancer died of cardiopulmonary toxicity due to unwanted toxicity of the CARs. The CARs went and attacked the lungs and the heart, and therefore, specific caution should be sought as new CAR T cells are developed for new diseases. There are HER2 CAR T cell therapies right now in the clinic are using slightly different single chain variable fragment antibody to target HER2 and appear to be safer. The first reports of successful CAR-19 in the clinic was in patients with lymphoma and patients with CLL. This is one patient in 2010 published out of the NIH with lymphoma, where patient had follicular lymphoma and had significant response lasting 4 months after CAR T cell therapy. But then the remarkable responses were after 3 patients treated at the University of Pennsylvania. Patients had CLL, another B-cell malignancy. And in these patients that received CAR-19, achieved complete remission, including in one patient was thought to have several pounds of disease prior to treatment, went in complete remission. And while it's only 3 patients, what we learned from that, we learned that the CAR-Ts are very potent. We also learned that they can differentiate into memory phenotype and persist. And that's what I was referring earlier to the concept of synthetic biology, because these CAR-Ts have 4-1BB in them, and 4-1BB drives the differentiation of T cells into memory T cells. So we learned that they can differentiate. We also learned that they are very potent. They eradicated pounds of disease. And we also learned about toxicities with cytokine release syndrome following these patients. But CAR T cells have been remarkably effective in acute lymphoblastic leukemia, especially in children and young adults. This is the first child who went on to establish her own foundation. Her name is Emily Whitehead, that received CAR-19 for acute lymphoblastic leukemia. And we learned that she developed significant cytokine release syndrome, which I am going to touch on later in the presentation. She was in the ICU on multi-organ failures. We also learned about treatment of cytokine release syndrome. And the patient was in remission in 2014 and is still in remission as in 2021, 9 years after CAR T cell, after single infusion. Highlighting similar to our previous patient with CLL, highlighting the potential curative, the curative potential of this therapy. And indeed, in acute lymphoblastic leukemia, CAR-19 have been remarkably effective. You see here on the left, this is the outcome of patients that relapse after chemotherapy and the transplantation in acute lymphoblastic leukemia. And this is the outcomes of patients that are treated after CAR T cell, similar group of patients that are treated after 1 infusion of CAR T cells, with a complete response rate anywhere between 80 and 90%, and a durable response rate between 50 and 60%, suggesting potentially curative nature of this therapy in this group of patients. And indeed, that led to somehow expedited FDA approval of CAR-19 compared the first pediatric patient that was treated in 2012 and 2013 to the FDA approval of CAR-19 in acute lymphoblastic leukemia in 2017 as the first gene therapy and cell therapy for treatment of cancer, which was in pediatric and young adults with acute lymphoblastic leukemia. But this carried on. This is a recent meta-analysis that we published showing that the efficacy of CAR-19 in acute lymphoblastic leukemia is not necessarily specific to that clinical trial, but across multiple clinical trials that are single center or multi-centers, that this efficacy has held true, with in this case about 40% progression-free survival and durable responses in these patients. Similarly, the results in B-cell lymphoma were quite remarkable, with about 70 to 80% of patients achieving responses after CAR-19 therapy and 30 to 40% of patients achieving durable responses. Importantly, if patients achieve response, they tend to do well and remain in complete response for a longer period of time, again, highlighting the curative potential of this therapy. This again held true across multiple multi-center clinical trials. These are the 3 multi-center clinical trials that were conducted for lymphoma using 3 different constructs. This is what's now called axicell, the therapy. This is what's called tisacell, and this one what's called now lysocell, and showing that a overall response rate of about 70 to 80%, and then a complete response rate of 40 to 50%, and durable complete response rate of 30 to 40%. Importantly, since the FDA approval of CAR-19, we have learned about what we call the real-world outcome that is not on a clinical trial, but actually of the FDA-approved therapy. And importantly, what we see compared to the clinical trial across different groups, that the outcomes are quite similar to what we saw in clinical trial as far as complete response rate, as far as overall response rate, the toxicities, and the use of therapy for toxicities, which I'm going to touch on later in this presentation. This highlighting the adaptation of this therapy beyond clinical trials. These are the 3 currently approved CAR T cells, CAR-19 in B-cell lymphoma. The 3 therapies are quite similar. The 3 constructs are quite similar to each other. All of them target CD19, and they all use the same clone, the same CD19 antibody. There is a slightly different variation. All of the constructs have CD3 zeta intracellular domain, and there is a slightly different variation in the hinges that attach the CD19 antibody to the signaling domain, and the difference in the signaling domain of the CAR, the co-stimulatory, where it's CD28 in axicell, and it's 41BB in tisacell and lysocell. Also, the way that the CAR is inserted, the axicell uses retrovirus, and the tisacell and lysocell use lentiviruses. Axicell is approved in lymphoma and in acute lymphoblastic leukemia, in large B-cell lymphoma and acute lymphoblastic leukemia, also in follicular and mantle cell lymphoma. And tisacell is approved in large B-cell lymphoma and acute lymphoblastic leukemia, and lysocell is currently approved in large B-cell lymphoma. But this is a moving target. We just learned last week at ASH, at our main hematology meeting, that CAR T-cell there have been trials to move CAR T-cell into the second line compared to transplantation, and in 2 of these clinical trials were positive, suggesting that we will likely see CAR T-cells now as a second-line therapy instead of third-line therapy in the practice in the treatment of B-cell malignancies. In addition, BCMA-directed CAR T-cell therapy, the BCMA is a different target, it's a B-cell maturation antigen, so this is CAR BCMA, has been developed for multiple myeloma, and has been remarkably active in patients with relapse and refractory multiple myeloma, and was approved earlier for multiple myeloma as well. So now we have CAR T-cell targeting 19, CAR-19 for lymphoma and B-cell malignancies, and BCMA CAR T-cells for multiple myeloma. This is the clinical trials, again showing that almost all patients that receive more than 150 CAR T-cells develop response and develop a response to the therapy, and then that response lasts the median response here was about a year, and there could be a tail end of the survival curve, suggesting that some patients could benefit from durable response, but it's still early to tell. So in summary, the current FDA approvals, we have CAR-19 in pediatric and young adults. This is tisacell, CAR-19 in lymphoma. We have 3 different products that are approved in lymphoma, and including a slight modification. This is the Brexucell that is approved in mantle cell lymphoma, or Tecartus. So this is approved in mantle cell lymphoma. It's a slight modification of the axicell. The construct is the same, but the manufacturing is a bit different, where here the manufacturing depletes CD19 to make sure that there are no leukemic cells that are being transduced. And so we have three constructs approved for lymphoma, and including a slightly modified construct that's approved for mantle cell lymphoma. And Brexucell was also approved for adult acute lymphoblastic leukemia, and ide-cel, the BCMA-directed CAR T-cell therapy that was approved for multiple myeloma. So really, over the last few years, immunotherapy has become a new pillar in the treatment of cancer. In addition to chemotherapy, radiation, and surgery, and now chemotherapy, radiation, surgery, and immunotherapy. Something was highlighted in the Science journal as a breakthrough of the year. And that was actually in 2013 when the clinical trials were just starting, and we had the checkpoint inhibitor revolution. So where we are now, and is that CAR T cells work in lymphoma and in leukemia. The majority of patients have responses, but about 30 to 40% have durable, complete responses. The limitation of CAR T cells is that the CAR T cells are associated with significant toxicities, namely cytokine release syndrome, neurotoxicity, and cytopenias. It works well, but the durable responses are still low. The durable response is 30%, 40%. We want to make this 100%. It doesn't work very well in solid tumor, which is an area of unmet need. And can we now capitalize and harness the effect of T cells and move to non-cancer applications? And then lastly, the current process is quite complex, costly, and somehow results in limited access to CAR T-cell therapy. As I mentioned, it's an autologous process. Patients have the cells manufactured, sent to the company, come back. It takes 3 to 4 weeks. It's extremely expensive. The delivery of CAR T-cell and the care of CAR T-cell adds to the cost, and the whole process results in limited access of CAR T-cell to major institutions and to certain fit patients who can tolerate the therapy. So what's the toxicities after CAR T-cells? We've learned that CAR T-cells come with cytokine release syndrome and with neurotoxicity. And we've learned that the cytokine release syndrome after CAR T-cell is characterized by high fevers, myalgias, low blood pressure, circulatory failure, and patients can be in the intensive care unit on pressors, on the ventilator. And it's associated with high levels of cytokines. It is, if you like, the CAR T-cells are living cells. CAR T-cells are infused. They see the cancer cells. They are proliferating in massive amounts in vivo. They are making their cytokines to kill the cancer cells, and patients are sick during this time. We also learned that IL-6 is important in this cytokine release syndrome, and that if we target IL-6 with an antibody that was available for the treatment of juvenile rheumatoid arthritis, we're able to prevent this syndrome, or we're able to treat cytokine release syndrome. This is tocilizumab, the antibody that has become FDA approved along with CAR T-cell for the treatment, and is currently the mainstay of the treatment of cytokine release syndrome. We are getting better and better in recognizing cytokine release syndrome early and treating that also early with tocilizumab. But mortality has been seen in the past with cytokine release syndrome. Neurotoxicity, on the other hand, is not very well understood. Patients can get confused, encephalopathic, occasionally can have atypical findings. It's seen with other CAR T cells, it's seen with CD19 targeted therapy with BiTEs, and deaths have been reported, especially if associated with brain edema. There are changes of the MRI on the neurotoxicity, tend to be transient, but if a brain edema is associated with the neurotoxicity has high mortality rate. And what did we learn with neurotoxicity? We learned that it is associated with disruption of the blood-brain barrier. So it seems to follow cytokine release syndrome. Patients have high elevation of cytokines. The blood-brain barrier is disrupted. Cells leak into the cerebrospinal fluid, into the central nervous system. such as T cells, B cells, and myeloid cells. And that seems to be associated with neurotoxicity. For example, this is analysis of one of the main clinical trials that led to the FDA approval of CAR-19, and you can see that the cytokine GM-CSF was most significantly associated with toxicity, with neurotoxicity, and also infiltration of CD14 positive cells, the monocytes, into the cerebrospinal fluid, were significantly associated with the development of grade 3 or higher neurotoxicity, suggesting a role for these cells. And based on that, there are several efforts to target these cells to prevent the development or to treat neurotoxicity. Because at the current time, we don't have active, effective treatments for neurotoxicity. So such therapy as IL-6, IL-1, and GM-CSF are currently considered relevant cytokines that are being studied across clinical trials. So these are the toxicities. The complete remission rates remains low after CAR T-cell, and that's a current limitation. As I mentioned earlier, it's 30 to 40% after lymphoma. But importantly, in solid tumor, CAR T-cell therapy is quite limited, the efficacy. And I think in my mind, there are three problems in solid tumor. One problem is, do the CAR T cells get into the tumor, trafficking of the CAR T cells, because it forms solid masses. And it does seem that it gets into the tumor, but I think this is an area that continue to need work to improve on. So I say that because, for example, in this study where mesothelin CAR was used to target mesothelioma, you see some partial responses, maybe stable disease. But then if you isolate, you take the cells out, you take the mesothelioma cancer cells out, you see that the cancer cell, the CAR T cells are there, and they are just inhibited by the tumor. So I think the main issue is that inhibition of the tumor by inhibition of the CAR Ts by tumor microenvironment that is quite immune suppressive. And then the other issue is the target identification, right? I mean, I mentioned the story with HER2 and being careful on finding a target for CAR T cells that is expressed on solid tumors, but not on the normal tissue. But for example, mesothelin is a good target. IL-13 receptor alpha 2 CAR T cells. This is a case report published in New England Journal of Medicine, showing that this patient achieved complete remission of glioblastoma, which is quite unusual in this aggressive disease. The complete remission was transient, but nevertheless highlighting the potential use of CAR T cell in solid tumors. So we, across the last 5 years, we've learned about toxicities of CAR T cells we learned about the limitation of CAR T cells, including the resistance and inhibition by the solid tumor, by the tumor microenvironment, including basic T cell defects, as well as the tumor mechanisms where tumor would escape the CAR T cell therapy. So with that, the current efforts and the next efforts are to address these limitations, address the toxicities, specifically the neurotoxicity, resistance to CAR T cells, develop strategies to make CAR T cells more inhibition resistance, if you like, more potent to overcome the tumor microenvironment. Also expand the engineered T cells into autoimmune diseases, and multi-target antigens to avoid the antigen negative relapse that we see after CAR T cell, where the tumor escape comes back with an antigen with CD19 negative as a mechanism of escape. Also addressing the cost and the access to CAR T cell therapy by attempting to move to an off-the-shelf allogeneic approach, skipping this complex autologous process, or using an academic CAR T cell factory, if you like, or generating CAR T cells in vivo. And over the next 10 minutes, I'm going to touch briefly on some of our and other efforts to expand CAR T cell, which I think we're going to see more and more over the next 10 years, more of these therapies in trials and in the clinic. So for toxicities, this is some of the efforts of our group. What we have learned is with CAR T cell toxicity that cytokine release syndrome developed 3 to 5 days and neurotoxicity developed 5 to 7 days. So what we did is that we developed a mouse model to mimic this toxicity after CAR T cells. And we see in these mouse models, the mice develop this cytokine release syndrome within 3 to 5 days. And they have elevation of cytokines similar to what we see in patients. This is using all human cells and humanized models. And also we see that in this mouse, in these mouse models, we see inflammation of the brain somewhat similar to what we see in patients, and also infiltration of T cells and activation of myeloid cells in the mice following CAR T cells. So we used these models and we tested whether we could target GM-CSF. It's a myeloid cytokine, granulocyte monocyte colony stimulating factor. If we could target that and prevent this syndrome. So we used that and we tested whether if we combine an antibody targeting GM-CSF with CAR-19, if that prevents the syndrome. And what we see that when we use the combination and we deplete GM-CSF, that mice do not lose weight. So mice that treated with CAR-19, they lose weight and develop this syndrome that is associated with significant elevation of multiple cytokines when we check in the mice. But mice treated with the combination of CAR-19 plus the GM-CSF neutralizing antibody, they maintain their weights and they have a significant reduction of cytokines that are associated with the development of this syndrome in human. In addition, when we image these mice, we see that in mice that are treated with CAR-19 alone, with the control antibody, they develop this syndrome that is a inflammation of the brain. And then we measure that, we see significant enhancement, significant increase in the enhancement of the MRI. But we see that it's reduced when we use GM-CSF neutralizing antibody similar to the baseline. So we were very excited about that. We partnered with some of the pharmaceutical companies in the field, and we moved using with Axicell that CAR-T, and we moved that into a phase 1/2 multi-center trial that we completed phase 1 and treated 6 patients across 10 centers right now. And we're getting ready with encouraging signal. We're getting ready to move to phase 2, phase 3. And then we said, if we are able to deplete this, if we're able to neutralize GM-CSF, why don't we incorporate that in the engineering of the CARs? And that's what we did. Using the CRISPR, we incorporated this into the manufacturing of CAR T cells, and we generated CAR-19 that don't make GM-CSF, but they continue to make other cytokines except for GM-CSF. We characterize these extensively, and then what we see is that they have enhanced anti-tumor activity and they have reduced level of GM-CSF. So we're excited about that opportunity to take it to the next step as an edited CAR T cell that goes to the clinic. We are seeing more and more of CRISPR-edited CAR T cells entering into the clinic, as I'll touch on later on. Again, highlighting the potential use of synthetic biology to incorporate multiple edits and generate an engineered CAR T that serve your purpose, if you like. Also, we're excited that a group in China, they utilized this concept with the GM-CSF knockout CAR Ts in the clinic, and encouragingly, they treated 3 patients, and all patients did not see neurotoxicity, somewhat corroborating our findings. So we look forward to this study, and we look forward to our study. As far as resistance to CAR T cells, a major part of resistance is inhibition of the tumor microenvironment. And this is an area that we and others are focused on, is to develop strategies to overcome this inhibition of the tumor microenvironment. This is in BCMA CAR T cell therapy. This is the FDA approved product. And you can see that all patients respond, but eventually the majority of patients relapse. And we might be having a tail where it's 20% or so of patients that remain in remission. This therapy is still new. But what we found is that the cancer-associated fibroblasts which are predominant in multiple myeloma, they tend to inhibit CAR T cells. They inhibit BCMA CAR T cells. We tested that extensively in the lab in vitro. And then we developed mouse models to understand that, and we were able to show that the cancer-associated fibroblasts inhibit the BCMA-directed CAR T cells in mouse studies. But importantly, when we engineered the CARs in a way to target both multiple myeloma as well the cancer-associated fibroblasts using two proteins, either CS1 or FAP, and we see that when we target the cancer-associated fibroblasts, we deplete them, but also we reverse this inhibition of the CARs. So we're also hopeful to be able to to start moving these strategies to the clinic to overcome inhibition by cancer-associated fibroblasts. Another area of the tumor microenvironment is the extracellular vesicles. They carry significant inhibitory cargo, and they are known to inhibit immune cells and to promote cancer cells. So we worked with that, and in one study, we found that the extracellular vesicles, especially the ones that express PD-L1, inhibit the activity of CAR T cells of CAR19 in the preclinical studies. You see that here is in mice that we treat them with CAR19 alone or with CAR19s that are co-cultured with extracellular vesicles. If we use CAR19 that are co-cultured with the PD-L1 high extracellular vesicles, the tumor activity is inhibited. This is the tumor volume compared to mice that receive CAR19 either alone or co-cultured with PD-L1 low extracellular vesicles. We are validating the role of PD-L1 high extracellular vesicles and determining the patient outcomes in patients receiving CAR19, and also understanding the mechanism of how is that happening. And what we found is that these extracellular vesicles carry an inhibitory microRNA cargo. And this microRNA cargo includes several microRNAs that target T cell pathways and that result in T cell exhaustion. And indeed, after the CAR T cells see these extracellular vesicles, their microRNAs are altered also, suggesting possibly they are transferred or modulated by this microRNA cargo. And that provided an opportunity to engineer the CARs in a way to prevent this inhibition. And that's what we did. We identified FOSL2 as a potential target for these microRNA and engineered the cells to express FOSL2. And by engineering that, we were able to overcome some of the inhibition of the T cells by the extracellular vesicles. This is using FOSL2 high compared to wild type CAR19. As we develop more of these therapies, it's quite important to pay attention on how we're going to move this to the clinic and move it in a safe way. By that, I mean these engineered cells that are overcharged and more potent. This is a story where CAR-Ts were engineered to have a TGF-beta dominant negative receptor. TGF-beta has a prominent role in the tumor microenvironment in inhibiting CAR T cells. And you can see in the preclinical study that the CAR-Ts, this is using PSMA targeting prostate cancer, that CAR-Ts that target PSMA that have TGF-beta dominant negative receptor, that they are more powerful in eradicating the tumor, and they also proliferate more in the blood of the mice. And that was exciting and got translated to the clinic. But what happened is, so this is a TGF-beta dominant negative PSMA directed CAR T cells. So this is a second step of engineering of the CAR T cells in the clinic. We're promising results with responses, but at the same time, with a massive proliferation of CAR T cells, there were 2 deaths due to neurotoxicity, which led to a current pause of this clinical trial. In my mind, it's a success to get the CAR T cells to work in solid tumor. And now we need to learn from that and figure out how to do that safely as we move into clinical trials. On the other hand, several efforts are attempting to engineer CAR T cells for autoimmune diseases. This is one story where, and when development where CAR T cells are engineered to target the B cell receptor and use that for B cell mediated diseases. This was a proof of concept developed and published in Science in 2018 using pemphigus as a model and showing that if you target the DSG3, the desmoglein 3 antigen, the B cell receptor, then you're able to preserve and prevent pemphigus. And this concept is currently moving in the clinic. Our group, on the other hand, is using the immune suppressive cells and mesenchymal stromal cells and trying to engineer them with CAR T. So what we've developed is engineering this to express a CAR using a unique virus with an enhancer. And then we targeted the CD3 cadherin axis to develop that for colitis. This axis has been widely sought after and recognized as an important axis for the development of colitis and graft versus host disease. And several therapies are currently either in the clinic targeting this axis with monoclonal antibodies or in clinical trials. So what we did, we engineered the MSCs to express a CAR, and then using CD28 stimulation, we see that the MSCs are more immune suppressive when they express the CAR compared to the wild type MSCs. And importantly, because these are stem cells, we show that they retain their stemness. So we are not differentiating them. They continue to be stem-like, and they are no different from the UTD MSC for the most part. And then we show that they are active in animal models in two things: preventing colitis in the graft versus host disease, and also in a tumor model, inhibiting the activity of T cell therapy. Encouraging results that we plan also to move that to the clinic. And in the last minutes, I'm gonna touch on the efforts to target the cost and the complexity of CAR T cell therapy. So one strategy and one question is in the field is whether to do CAR T cell in a centralized or a decentralized way. This is the company model where you ship the CAR Ts to the company and have the CAR Ts manufactured and sent back is the right model, or whether Mayo Clinic or other universities and academic centers should be able to manufacture the CAR Ts on site and give that to the patient. And it's a question, each one has its own pros and cons, but what we have is established a process to generate CAR Ts in-house and to allow us to move innovations to the clinic, as well as give CAR Ts to patients when it's a much shorter period of time. And we're looking forward to examining this as a potential strategy. Off-the-shelf CAR T, this is a third-party CAR T, is becoming increasingly used, and more clinical trials are currently launching and advancing. This is one clinical trial where CAR-19 is used from a third party, so it's allogeneic. The CARs need to be edited, they need to have an additional editing step where the T cell receptor needs to engineer to be knocked out to prevent graft versus host disease, and another edit to prevent rejection. And that's what this group did and published last year. The results are encouraging, suggesting the feasibility of this approach. This would be a CAR T that's off the shelf instead of doing an autologous process. That would be CAR Ts, a third party from normal donor off the shelf. So the results here they are a bit inferior to the autologous CAR T, but having activity here, highlighting the potential use of this platform to improve on and move that to become a mainstay treatment. Similarly, NK cells have been used as a separate cell type that can be used in an allogeneic off-the-shelf platform. This is work by the group at MD Anderson, using NK cells, engineering them with a CAR and giving that to the patient, and they are derived from cord blood. And again, they used B-cell malignancies, and the early results were encouraging, that the overall survival and the peripheral-free survival of the progression-free survival of patients was quite encouraging enough to move this from phase 1 to a larger phase study. So we look forward to learning more of. There are over a dozen different allogeneic CAR T approaches in the clinic. I always like to end with this slide. This is in 2013 when I started to work in CAR T-cell therapy. There were 3 groups working: the University of Pennsylvania, the Fred Hutch, NIH. Each one has their own partner. This is in 2019, the different companies and products, and that's even 2 years old. So in summary, I think autologous CAR T cells currently is approved in lymphoma and B-cell ALL and myeloma. The initial response rates are high, but we're excited about the potential durable response and the curative potential, which is 50 to 60% in ALL, 30 to 40% in lymphoma, a bit lower in myeloma. The toxicities, we're learning more and more how to manage that. Management of neurotoxicity remains an area of unmet need, and new therapies are in the clinic. The platform is currently complex, expensive, and it's time consuming. I think what we're going to see more and more of these edited CAR T cells that enter into the clinic. We want to make sure that the edit does not impair CAR T cells, does not make them more toxic, and instead making them less toxic, making them more effective. And we're going to see more engineered cells for other solid tumors as well as autoimmune diseases. And hopefully we'll see more of the off-the-shelf CAR T cells to address the complexity and the access issue. So with that, I'll stop here. I'll thank all of our lab members and collaborators and our funding sources. And thank you all for listening, and we'll open for questions. I'll hand on to you, Lisa.
Thank you, Dr. Kenderian, for your very insightful presentation. We can now proceed to the question and answer section of our presentation, and we do have a few questions. First, do you think the allogenic off-the-shelf CAR T will be as effective as the autologous approach?
Yeah, very good question. So if you take the allogeneic CAR Ts in the lab and compare them to autologous CAR Ts, they can kill in a similar way, so they are as effective. But it seems that, so the allogeneic CAR Ts, they need modification of the T-cell receptor, of the TCR. And then as you modify the TCR, you wonder what's the TCR doing in the CAR T cells? Is it contributing to the function of the CAR T cells? So when you knock out the CAR T cells, the TCR, the CAR Ts continue to be effective. But what we're seeing is that perhaps they are not lasting as long in vitro and in mouse studies. And we're learning the same thing from the patient studies, where the allogeneic CAR T says perhaps they are not lasting as long. The question is that, do you need the CAR Ts to last long? I think in acute lymphoblastic leukemia, you need them to last long because it's an aggressive disease and relapses. But for lymphoma, you need them to last somewhat. And then myeloma also, you need them to last somewhere. I think in lymphoma and myeloma, where the persistence might not be of that much of a critical issue, we don't know that yet. But I think in these 2 diseases, allogeneic CAR Ts can have a potential. The other advantage with allogeneic CAR T is because you're doing an edit in the T cell, and you can add another edit, and in addition to knocking out the TCR, and another edit at the same time, because you're using a different platform, so you can make them potentially stronger. There was a PD-1 knockout, TCR knockout T cells that were published in Science last year in solid tumor and in multiple myeloma. So I think we're excited that ASH, there were at our hematology meeting, there were a lot of presentations on the allogeneic CAR T. I think they have potential, especially in my mind, in diseases where persistence is not a major issue.
Thank you. For new strategies in CAR T cell therapy, how do you balance the benefit of something new that could improve versus harm CAR T cells?
Yeah, thank you, Lisa. That's another good question. I think we learned from the TGF beta dominant negative receptor and others that we need to be careful. I think special attention and a lot of preclinical studies in attempting to understand and make sure that the CAR proliferation is controlled. It's not, this is living cells, right? And they're potent cells. And as you make them more potent, there is risk that you'll come with an unwanted side effects, toxicities. So more careful preclinical studies, careful animal studies, and then really careful. You can get as much from animal studies, but really careful phase 1 clinical trials as you move this to the clinic. But
Thank you.
it's a good question, and it's a very important question, I think.
Thank you. You had touched toward the end of your presentation on NK cart. There just was a question, maybe if you could just expand briefly, if there's anything else you would like to comment about that approach.
Yes, certainly. Certainly. So, I mean, it's exciting, the NK cells. The advantage is it's a potentially off-the-shelf platform. The challenge is the bottlenecks, if you like, is how do you expand the NK cells well? And also, how do you engineer them to express enough CARs on them to be effective? And I think over the last few years, we've continued to learn, and there continue to be incremental knowledge on how to address these bottlenecks. There are several NK cell therapy that are entering the clinic, engineering the NK cells using either virus or non-virus, and expanding NK cells using different approaches. The results from the MD Anderson trial are quite encouraging. They also seem to persist somewhat, the NK cells. I think that's we'll need to learn on how much they persist. We might run into the same issue as the CAR-Ts. Also, we need to learn about how well they do in treating high burden disease. The number of patients that are treated with NK CAR is significantly smaller. It's slow. It's currently low, but it's certainly an exciting area that we look forward to see what the clinical trials show. In addition to that, there are a few approaches. For example, there's CISH knockout NK cells as a potential strategy to improve on the current NK cells. So there are, just like CAR T cells, there are a lot of efforts to make them better, if you like, and we hope to see that in the clinic too.
Thank you. You had mentioned about the challenges to access CAR T therapy. What do you think can be done to help increase patient access and then help ensure a more equitable process?
Yeah, thank you. That's another big question too, Lisa. See, the current challenges of the access is that the process is complicated. It's 3 to 4 weeks from the time the patient gets the blood sent to the company, they're sent and sent back. It's extremely expensive. The product itself, it's more expensive to deliver the CAR T, to give that with all the complication. So as such, it's only done in the major academic centers, similar to bone marrow transplantation, if you like. So one question is that, can we do that safely as an outpatient, so that other more centers can do CAR T? And it seems that we're making some positive steps that way. The other important aspect is the allogeneic CAR T, and whether that is going to be it'll be more accessible as far as time, but whether that's going to be less expensive and unclear than the current CAR T platform. But hopefully over the next 10 years, we'll see some of this getting into FDA, into becoming into standard of care. And the last thing is that if we're able to do it at site, are we able to manufacture the CAR T? Could there be a platform to make the CAR Ts on site instead of making it at the company? And could there be such a structure? It's highly complicated, the process, highly regulated. So right now, even the manufacturing on site can be done at the academic institution, but could there be a process where several institutions can manufacture instead of sending it? And because that would reduce the cost, having it manufactured on site, and also would make it available in the manufacturing period, which is 6 to 10 days to patients, and even now 4 days at cases. So these are, I think, areas that we'll hope to address in the next 10 years as well.
Thank you. Dr. Kenderian, thank you so much for your time and sharing your knowledge today. Also, thank you to the audience for joining us. I did want to share with the group that our next presentation in this series is on January 18th. And the topic will be recent advances in pharmacogenomics. Please register, and we'll look forward to seeing you on January 18th. This concludes today's presentation. Thank you again for tuning in, and have a great day.